absolute pleasure to introduce Dr. Abhilash Koratal, who has graciously joined us all the way from the United States for the 4th Nephrocritical Care Review course here in Visakhapatnam, India. Dr. Koratal needs no introduction. He is a distinguished nephrologist and is a globally renowned expert in the field of point-of-care ultrasound. With numerous impactful publications and groundbreaking contributions to the integration of POCUS in nephrology and critical care, he has been instrumental in shaping how clinicians approach bedside diagnostics. Today, we are fortunate to have him, and he will enlighten us with his talk on comprehensive POCUS, how to integrate at the bedside using case-based scenarios, a subject that promises to revolutionize the way we approach bedside ultrasonography. With Dr. Koratala's depth of knowledge and ability to simplify the complex concepts, I am, as the course director as well as General Secretary of Nephrocritical Care Society, is very confident that this session will be an enlightening experience for all of us. Let's welcome Dr. Abhilash Koratal from University of Wisconsin, and he is the clinical director of imaging, and also he is the clinical nephrologist from United States of America. Thank you, Dr. Koratal, for joining us.
Thank you, Dr. Sahu, for the kind introduction, and it's always a pleasure to be here. And nephrocritical care is a pretty new branch, I should say, even in the US. So I'm glad you are raising awareness. Good morning, everyone. So in this lecture, I'm going to give some overview of point-of-care ultrasound use in ICU and nephrology critical care context. Obviously, 1 hour or like for that matter, like even a one-day course is not enough to really elaborate all the concepts of point-of-care ultrasound. So instead, I'll just focus on the core concepts and clear some misconceptions that we encounter in day-to-day practice. First of all, what is POCUS? POCUS, or point-of-care ultrasound, is the ultrasound examination performed at the bedside, that is, at the point of care, by the clinician, not the radiologist, by the clinician himself or herself, to answer focused clinical questions. And answering these focused clinical questions will either provide the diagnosis or help you to narrow the differential diagnosis. Basically, these are the questions that you have in mind after careful history taking and performing physical examination. You still have some questions, and answering these using a bedside tool like ultrasound will facilitate the management. And you can use point-of-care ultrasound to guide a bedside procedure. This is more known application of point-of-care ultrasound. It's most of the time, like most centers don't do any procedures like dialysis catheter placement or kidney biopsy without some sort of imaging guidance. And ultrasound is the most commonly used imaging tool to guide the procedures. But in this presentation, we'll just confine to the diagnostic aspect of point-of-care ultrasound because that's less known and subject to more misconceptions. What are some examples of focused clinical questions? Does this patient with acute kidney injury have hydronephrosis? How does the kidney size look like? Does this patient with hypotension during hemodialysis have pericardial effusion? How is the left ventricular systolic function? Is there right ventricular failure, and so on? Or does this patient with shortness of breath have pulmonary edema or pleural effusion, or maybe nothing, and the patient has a pulmonary embolism, so you might find clear lungs. So that would help you to either diagnose something or narrow your differential diagnosis in the mind. And POCUS is evolving as a component of physical examination. Like the traditional pillars of physical examination are inspection, palpation, percussion, and auscultation. And insonation, or using ultrasound, is now considered the 5th pillar of bedside clinical examination. And like, why do we call it a physical examination? Because physical examination is a process of evaluating objective anatomic findings at the bedside, and you gather some data from that and integrate that data thoughtfully into patient's history and the clinical context. And that's what exactly point-of-care ultrasound is helping you to do. These are all the point-of-care devices we are familiar with: reflex hammer, flashlight, tape, stethoscope, tuning fork, and the sonoscope or ultrasound has joined nephrologist toolkit to facilitate bedside physical examination. And this is how the medical education is also changing. On the left, you see the classic Rembrandt painting from I think 1600s, where Dr. Nicholas Tulp, this guy here, is teaching medical students anatomy by showing them how to dissect a human body and showing all those parts. Now the medical schools are using point of care ultrasound to show the uh, students anatomy and as well as physiology in some cases, and that way they better know how to integrate anatomy and physiology as they move forward during their medical school years. So that's the brief introduction to point of care ultrasound. And so let's come to the clinical context of acute kidney injury in the ICU or anywhere, acute kidney injury in the ward or wherever. We typically have some questions about fluid, like should I give this patient with acute kidney injury intravenous fluid, or shall I remove fluid from this patient, or does the patient's pump need help? For example, a patient who is hypotensive can be hypovolemic, that is, could be benefiting from fluid, or hypervolemic, that means you remove some fluid and reduce the pressure on the left ventricle because of the right ventricular overload and volume overload. That patient's blood pressure might improve with volume removal. Or this hypotensive patient might require uh, uh, a medication to make the heart squeeze better. That is a vasoactive agent. And once you answer that initial question, then you have further questions. Did I give adequate amount of fluid? Is the circulation refilled properly? Or did I remove adequate amount of fluid? Or should I consider more aggressive diuresis or ultrafiltration? So all these things we encounter in day-to-day life as nephrologists and intensivists or nephrointensivists. Um, and so it appears that all these questions revolve around fluid, right? That's why we commonly say, I want to assess a patient's fluid status, I want to assess a patient's volume status. And we are saying we are going to use point of care ultrasound to do that. But in reality, what does point of care ultrasound tell us? It's not really measuring the blood volume, right? So it's telling us about whether there is flow or not, that is blood flow or not. And if there is flow, what is the direction of the flow? And what's the flow pattern? Is the blood flowing in a laminar fashion or is it a turbulent fashion? And what's the flow velocity? So these are the things point of care ultrasound is telling us. And we use those parameters to calculate pressures within the vascular compartment. And we assume that if the pressure is high, the volume is also high. That assumption may or may not be always right, because there are pure pressure disorders like pulmonary hypertension or pericardial effusion and so on. But the point is, using ultrasound, you are not directly measuring the blood volume. That's an important concept to understand. So volume status assessment itself is a wrong terminology. So we should ideally say, I want to assess a patient's hemodynamic status. That's what you're doing at the bedside. And so what doesn't ultrasound tell? Ultrasound doesn't tell you about the actual volume. And if you really want to measure intravascular volume, the only way at the bedside is using radiotagged albumin. So you inject a known amount of radiotagged albumin, and depending upon how its concentration changes, you take blood samples at defined time intervals, and you calculate what's the approximate blood volume. Even though you know that, I don't know, like if we know how to use that data properly into day-to-day clinical practice. And this radiotagged albumin thing previously was confined to research settings, and even in the US, I think it's only available to do at the bedside, only at a few centers, mainly because we don't know what to do with it. And so, yeah, that brings us to the hemodynamic assessment. And when we say hemodynamic assessment, we should conceptualize that as evaluating the whole hemodynamic circuit. What do we want to know about patients' hemodynamics? It's not, I mean, if ultrasound cannot measure the intravascular volume, we want to know how is the forward flow. We want to know the blood pressure. We want to know the stroke volume. Sometimes the blood pressure might be fine, but the heart might not be squeezing well, and the stroke volume might be low. That patient could be having impending heart failure, impending cardiogenic shock. and the blood pressure could still be maintained because of vasoconstriction. So you want to know what is the stroke volume. Or you can have a patient with hyponatremia, and your IVC, which tells you about the right atrial pressure or central venous pressure, might be small and collapsible, but that doesn't differentiate between euvolemia and hypovolemia. So you want to know what is the stroke volume. If the stroke volume is low, it's most likely hypovolemia. If the stroke volume is preserved, then it's most likely euvolemia. Or you can have a patient with um, cirrhosis and hyperdynamic circulation. In that patient, you can have high output cardiac state, high output cardiac failure. So if you measure the stroke volume and estimate cardiac output from that, the cirrhosis patient can have a cardiac output of 10 liters. Then you should question yourself, again, why should I give this patient with such a high cardiac output albumin or crystalloids? Because the sole purpose of giving crystalloids or colloids is to improve your forward flow, improve your cardiac output. If the cardiac output is already high, there is no point. So there are several situations in nephrology and critical care where measuring stroke volume would be really helpful, in addition to the blood pressure. So that's a forward component. And the next component of hemodynamic circuit is the effect of the backward pressures of the heart, increased backward pressures. So what happens if your left-sided pressures are elevated? More specifically, if the left atrial pressure is elevated, um, there is increased pressure here, so the water is going to accumulate in the lungs. We have increased extravascular lung water, pulmonary edema, and that can be measured using point of care ultrasound. And how about the right-sided pressure? So if your right-sided pressures are elevated, the back pressure would travel down into the organs, and you have congestive organ injury, congestive nephropathy, congestive hepatopathy. So in those cases, you need to remove volume. So hemodynamic circuit assessment is done in three parts: forward flow, effects of elevated left heart pressures, and effects of elevated right heart pressures. So let's go one by one. Um, by by basically clearing misconceptions, right? So you said the talk is about. Most people think like as volume status is inferior vena cava ultrasound. That's a highly prevalent misconception. So is nephrology POCUS equal to IVC ultrasound, or is volume status assessment is equal to IVC ultrasound? We just said that volume status assessment as a terminology is essentially it shouldn't be used. So is IVC ultrasound equal to hemodynamic ultrasound? I mean, you can guess it's not, because we already said like hemodynamic circuit must be evaluated in three parts, and IVC is only telling you about one portion of the hemodynamic circuit. So what is IVC and what does it tell us? I know some of you might be familiar with some ultrasound to some extent, and some of you might not be. So it kept it relatively basic so that everybody can be on the same page. So IVC is a vessel that carries blood from the lower part of the body, and it joins the right atrium. So if the right atrial pressure is elevated, you can assume that the IVC is enlarged, and it's big, and it has less respiratory variation. What does respiratory variation mean? When you inspire, your intrathoracic pressure is low. If your intrathoracic pressure is low, the right atrium is sucking the blood from the inferior vena cava. So the inferior vena cava is expected to collapse during inspiration. So basically, if the right atrial pressure is elevated, the vessel will be big and the respiratory variation will be minimum. And if the right atrial pressure is not elevated, the inferior vena cava will be small and it collapses during inspiration. That's the concept. So basically, inferior vena cava reflects right atrial pressure. Right atrial pressure is essentially central venous pressure that you measure using a catheter. Assuming there is no stenosis between right atrium and IVC, or right atrium and SVC, it's right atrial pressure is equal to central venous pressure. So here is your sonographic image. This is the inferior vena cava, and this beating structure here is the heart, and this is more specifically the right atrium. So this vessel here is joining the right atrium, and where my pointer is here, that's a point you are looking at to see the diameter of the inferior vena cava and its collapsibility. And this structure here is the hepatic vein. So you just go slightly below the hepatic vein IVC junction and see what its anteroposterior diameter is and how much it is collapsing during inspiration. Generally, if the IVC is more than 2.1 centimeters, that's considered to be dilated, and less than 2.1 centimeters is considered to be normal size. And it's for most people's IVCs are about 1.5 to 2 centimeters in adult population. So by the time you reach 2, probably the eye vessel is already dilated. But these are the cutoffs generally you remember um, for standardization purposes. So if the vessel is more than 2.1 centimeters and collapsible by less than 50% during inspiration, then the right atrial pressure is elevated and you estimate it to be about 15 millimeters mercury. And if the vessel is less than 2.1 centimeters and collapsible by more than 50% during inspiration, then you consider the right atrial pressure is not elevated and you give a estimated value of 3 millimeters mercury. And if it's in between, the vessel is big, but it's very much collapsible, or the vessel is small, but it's not at all collapsible. So then you assign an intermediate right atrial pressure of 8 millimeters mercury. So that's what you will find in echocardiography reports. In echocardiography, IVC is a standard component used to estimate the right atrial pressure. So basically, why do we care about right atrial pressure? Because if the right atrial pressure is high, the patient is unlikely to benefit from intravenous fluids. You have a patient with AKI, you are thinking I should give fluids, but if your right atrial pressure is already high, you have to think twice. Does this patient really benefit from intravenous fluids? Or if I give more fluids to a patient with elevated right atrial pressure, it's going to accumulate elsewhere. So it's going to third space. So IVC POCUS is relatively easy to perform. That's why it's popular. That's one of the reasons. Because IVC is a vessel somewhere here, right? So in the heart, the right atrium is somewhere here, and you have IVC, you have aorta, and you place the transducer in the subxiphoid area. You'll find the IVC in most patients, of course. And sometimes subxiphoid area is not accessible or it's difficult because of distended abdomen or gaseous abdomen, then you can image the IVC from the side also. The ultrasound beam comes like this. Here, the IVC is here in this ultrasound image. Structures closer to the transducer would be on top, and structures away from the transducer would be at the bottom. So your another tube here is the aorta, because as the beam comes from here to here, aorta is at the bottom and IVC is at the top. And all this area is liver, and here is your hepatic vein. So IVC is basically easy to access either from subxiphoid area or lateral aspect. But there are several pitfalls of inferior vena cava ultrasound, especially when you use it in isolation. If you just rely solely on IVC ultrasound, that's going to be a problem. So let's see some examples. Is it the plethoric inferior vena cava? That means is this a very dilated IVC that's not really moving much with respiration? It does appear like that, right? So here we have the liver, here we have the vessel, and here we have the beating structure. And like when you are learning ultrasound, several people tend to think this is a plethoric IVC, so the right atrial pressure is elevated. But in reality, this is the inferior vena cava image obtained from the same patient. So here you can see the IVC is very small and completely collapsible as the patient takes in breath. So here you have totally different assessment, right? If you rely solely on IVC, you think, oh, this patient with AKI has elevated right atrial pressure. I'm not going to give fluids. Maybe patient has heart failure. I should refer to a cardiologist to get a full echocardiogram and so on. But what you're actually missing here is this vessel is not IVC. The clue is it's separate from the liver. And you see all this white area between the liver and the vessel. So that's aorta. So IVC passes through the liver, as in the actual IVC here. You can see here is the liver, here is some portion of the liver. So IVC should pass through the liver, whereas this vessel here is separate from the liver. And also you can see anterior branches outside the liver. So these are celiac and superior mesenteric arteries. So IVC doesn't have any anterior tributaries outside of the liver. So that's a big clue. So the point is, again, like if you rely solely on IVC and if you mistake IVC for the aorta or aorta for the IVC, you're going to make mistakes. And the same question, I put this upon Twitter, and only 26% of the people said you cannot estimate right atrial pressure based on this image, and rest of the respondents chose some number, and most people thought it's 15 millimeters mercury or elevated right atrial pressure because it at first glance it does look like inferior vena cava. So knowledge of anatomy is very important, and essentially, like POCUS is anatomy and common sense, right? Common sense is basically interpreting the findings in the appropriate clinical context. it's like surgery. Surgery is also they say it the same way, like anatomy and common sense. Anyway, so how about this image here? So this is a patient with cirrhosis. We have the liver, and fluid is black on ultrasound. So this thing is ascites here. And then the person who did this point of care ultrasound labeled this as inferior vena cava. So this is a patient with cirrhosis, and normally guidelines say give some albumin, but because the IVC is plethoric, I'm not going to give albumin. That's what the nephrologist says. But realistically, the nephrologist is wrong, because by the same concept that I said in the previous image, this vessel is separate from the liver. It's not attached to the liver. Actually, the IVC is this small sliver like thing there. So in most such cases with cirrhosis, you have increased intra-abdominal pressure, and the IVC becomes very small. And sometimes there is low right atrial pressure because of the traditional thinking that they have diarrhea from lactulose and all those things and other causes of fluid depletion. Or sometimes it could just be a false reduction in diameter because of increased intra-abdominal pressure and ascites. And in those cases, you should look at the internal jugular vein to get a real idea of right atrial pressure. So in this patient also, if you think aorta has IVC, you will reach false conclusion. And also inferior vena cava is a three-dimensional structure, right? A vessel is like a cylinder, and you're using a two-dimensional modality, that is ultrasound, to slice the vessel. So when you're imaging the IVC in the long axis, you are assuming that your beam is cutting through the center of the vessel, and you're getting the maximal anterior-posterior diameter. That's why you're relying on some number of 2.1 centimeters as a cutoff. However, your beam could be slicing at the periphery of this three-dimensional structure, in which case you'll get falsely lower diameter. So you might be getting a diameter of 2.5 centimeters because you actually got the anterior-posterior diameter, and now your friend comes and does a repeat ultrasound 2 hours later, and they slice the vessel somewhere here at the periphery, and they might say, oh, the vessel is only 1.8 centimeters. So my friend gave diuretic, so the vessel has responded very well. But in reality, it might actually be the same diameter. So that's a problem. So that's called the cylinder effect that we must be aware. And so the way to avoid cylinder effect is once you put the transducer in the subxiphoid area, you have to fan it, that is tilt it from side to side, and see where you're getting the maximum anterior-posterior diameter, and that's where you would record it. Or other way is just look at the vessel in its short axis or transverse view, and then there is no confusion, right? You'll find a vessel in like a circle or an oval, and then you can definitely measure anterior-posterior diameter in the middle of the vessel. So here is a nice real-life example, right? So here you have inferior vena cava. It's not at all collapsing. This guy says it's 2.02 centimeters. And this patient, we have another operator here. Nothing has been done to the patient. No diuretics, no fluids, nothing. And he or she gets a diameter of 1.74 centimeters. Without doing anything, just because of the cylinder effect, there is a 3 millimeters discrepancy in the IVC diameter, right? That's substantial, because we, as nephrologists, we tend to be very nerdy and read all the papers. We're very good with the literature and all that. So when you read the studies, it sounds very interesting, as if like IVC is so easy and it's going to solve all your problems. For example, in this study here, they looked at the IVC diameter pre and post dialysis, and they said it changed from 14.2 to 12.3. How much is the difference here? It's about 2 millimeters, right? Just by that cylinder effect, you got 3 millimeters in the previous slide. And there is another study. They looked at pre and post furosemide, and IVC diameter changed by an average of 0.21 centimeters and 0.15 centimeters. Essentially, it's in practical terms, it's meaningless, right? I mean, for research, it really looks good when you look at this data. It seems that you're doing something, and IVC is changing in response to your treatment, and you can use it as a monitoring tool or diagnostic tool. But if you are not good with the technique, if you fall prey to cylinder effect, this essentially becomes meaningless. So this is statistically significant, but is it clinically significant? Probably not. And actually, if you make the decisions based on the data, it might lead to patient harm. How about this one here? Is this a collapsing IVC? Here is your scale. So the IVC diameter seems to be pretty big, right? And this is IVC for sure. This is not aorta. I'm not tricking you. This is attached to the liver. There is no space between IVC and liver. This is definitely more than 2.1 centimeters. I think it's around 3 centimeters or so, but it seems to be like fully collapsing though. Like, would you say it's like intermediate right atrial pressure because it's big, but it's like very well collapsing. It's almost 100% collapsible here if you look at it. Um, so the problem there is it's not a real collapse. Whatever you are looking at here is the junction between the right atrium and the inferior vena cava. You should never measure the inferior vena cava diameter at the junction of the IVC and right atrium because there is diaphragm and diaphragm exerts pull. So that feels like it's collapsing. So you just go slightly lower and measure somewhere here and you can clearly see that it's not really collapsing with inspiration or it's not changing diameter with respiration. So that's one pitfall. And also when we say like 50% collapse or whatever percent collapse, depending on paper you are reading, we are assessing that with a sniff. Remember that sniff is deep inspiration, basically as if you're like sniffing a flower um, to smell it. So what does it mean? It depends on the strength of breath. Say you have a 30-year-old muscular man admitted to the hospital and a 70-year-old frail woman is admitted to the hospital. Both of them might be sick, but still that 30-year-old guy will have a higher strength of breath. And as they improve or deteriorate during the hospital course, the strength of breath changes. So that becomes a little ambiguous. So that's why I don't rely so much on those cutoffs like 50%, 25%, 40%. It rarely matters clinically. So pay attention to that. And also like those collapsibility definitions are in spontaneously breathing patients because they can sniff. In mechanically ventilated patients, they cannot sniff. So you cannot really use IVC to precisely estimate right atrial pressure in mechanically ventilated patients. That's a very important thing to understand. However, like, I mean, if the patient is mechanically ventilated, the IVC is like 4 centimeters. Yeah, most likely right atrial pressure is elevated. Or the patient is on mechanical ventilation and the IVC is like 1.1 centimeter. Yeah, most likely the right atrial pressure is not elevated. So it's still useful at extremes, but not at the intermediate values. So here is a table showing like a lot of studies done in mechanically ventilated patients trying to correlate inferior vena cava with right atrial pressure. You can see the correlation is like, I mean, it's poor essentially. It's all over the place. There are some studies where it correlated reasonably, but most of the studies, it's pretty poor. And how about this one here? Is this 100% collapsible IVC? So first of all, this is not aorta, this is IVC. It's attached to the liver. And it feels like as the patient is breathing, it's completely collapsing. But it doesn't really look like the collapse that we saw previously, or the initial normal IVC image that I have shown you, which was nicely collapsing just below the hepatic vein IVC junction. This seems to be like collapsing too much, and the IVC is not even that small. It's of reasonable size, about 2 centimeters or so. So what's really happening is you get a better understanding if you look at this IVC in transverse. In transverse, this is the long axis plane, or the left side image plane corresponds to that dotted line. And this round structure is the IVC here. So as you can see, as the patient is breathing, there is lateral translation of the IVC. It's just that the IVC is moving away from your ultrasound plane instead of staying in the center. So you're not really assessing its collapsibility. So by the time patient is taking in a deep breath, your beam is just passing to the vessel. That's, liver, sorry. That's why you're feeling like the vessel is collapsing, but it's not. So that's the use of looking at the IVC in transverse view. By looking at the IVC in transverse view, you can avoid cylinder effect as well as artifacts because of lateral movement of the IVC. And this is a transverse view sonographic anatomy. So you're still in the subxiphoid area, but cutting it in the short axis. So as we said, like IVC is within the liver, and you see hepatic veins going towards the IVC. There are 3 main hepatic veins. And here is the aorta. Aorta is always separate from the liver. That's what I mean. I meant like when I showed you the previous images also. And IVC is within the liver. And in the middle, you have shadow. As you know, bones and stones give shadowing on ultrasound. So that's a vertebral shadow here. You have the aorta, and this is the IVC. This is a nice example of a normal IVC. As you can see, it's oval in shape, and it's essentially 100% collapsible with respiration. So it seems like transverse view of the IVC has several advantages, right? So why not just do transverse view? So that's what this nephrology fellow thinks and does IVC transverse view and says, oh, this IVC is pretty big. I'm gonna diurese this patient with AKI. It's circular. Normally, like IVC is oval, right? So as it becomes filled with too much fluid, then it becomes more circular. So if you generally see a circular IVC, it's already full. So that's what it appears like here. This vessel seems to be circular and collapsing, or only maybe a little change with respiration. But the problem here is that this person is not really looking at the IVC. This person is looking at this structure, which is the right atrium. So this is actually the subxiphoid four-chamber view of the heart. And you have the four chambers here. If you look at it, the heart is going to appear here. Okay, see that? So this is the right atrium. And this tiny little thing here, I'll show you. This one is the inferior vacuum. It's very small. And to confirm that, you look at that in the long axis also, and you can see it's a very small vessel here. So the point is, like, mistakes like this can happen when you just rely on one view. One view is no view in point of care ultrasound world. Remember that. So look at the IVC in both axes whenever possible. About this case here, we have a same patient. These two images are obtained few seconds apart. No treatment changes were done. So we are looking at a M mode image of transverse view of the IVC. So here is the transverse view of the IVC. M mode is nothing. Like you get a cursor like this, and you want to measure the middle of the vessel, like you for the respiratory variation in the diameter, and that M mode is like a graphical representation of this plane, this particular plane where this line is. It graphically represents it over time. So that way, like if your line is here in the middle of the vessel, you can see how it is changing over time. That is precisely during respiration. So this is the inferior vena cava, and it seems like it's not changing with respiration at all, right? But here it feels like there is very significant respiratory variation. It's more than 50% collapsibility. Same patient, nothing has changed in terms of treatment, but the vessel seems to be collapsing a lot more. And assume that the strength of breath hasn't changed, and we are not playing tricks there. So what's happening here? So we are having site ambiguity. What it means is, in long axis, you know exactly where the right atrium is. So IVC is entering the right atrium here, and you know where the hepatic vein is joining the IVC somewhere. So you know exactly where all these things are. But when you are cutting the vessel in the short axis, you might be cutting it here, you might be cutting it here, you might be cutting it here. It's little difficult to know exactly where you are unless you are like very familiar with anatomy and you have considerable experience. So that is called the site ambiguity. And what was happening in the previous cases are like initially when the vessel is not really collapsing, that's at 0.2. So that's actual IVC that's not collapsing. This IVC is plethoric. However, like in this image here, the collapse is because of the plane is passing through the IVC right atrial junction, as we previously talked about. So never measure IVC right atrial junction because there is always some diaphragmatic pull. That's not real respiratory variation of the IVC. Again, one view is no view. How about this one? This one looks like a pulsatile vessel, right? Is it a vein or artery? Is this IVC or aorta? Because we are traditionally taught like arteries are pulsatile, and when we are putting internal jugular vein catheters, we are asked to identify artery by its pulsatility and vein by its respiratory variation, in addition to knowing anatomy, of course. So this image here, it's very pulsatile vessel, but it's still IVC, because if you know anatomy, you know it's within the liver here, and it's not outside the liver. And we said aorta is outside the liver. And you can see the hepatic veins are going towards the IVC. And here is another nice example. Here is a vertebral shadow. Here is the aorta. Here is the IVC within the liver, which is oval and very pulsatile. Actually, this vessel here is pulsatile than aorta. So the point is IVC can be pulsatile. Normally, I mean, IVC is pretty compliant, right? So the pulsations might not be that obvious. But if somebody has hyperdynamic circulation, some volume depletion, or patients with cirrhosis often have hyperdynamic hearts. So in those patients, IVC is frequently pulsatile. And also sometimes the patient has severe tricuspid regurgitation. So with every beat, the blood is going back into the right atrium and back into the IVC, obviously. So the IVC can be pulsatile in tricuspid regurgitation also. But in those cases, patients tend to be a little bit hypervolemic and the IVC is a little bigger than this. But these two images were obtained from my clinic patients with heart transplants. And heart transplant patients usually have hyperdynamic hearts. Their heart rate is pretty high because of sympathetic denervation during surgery. The point is IVC can be pulsatile. And this quiz also I put up on Twitter, and looks like only about 60% of the people got it right, and the rest of the people thought it's some kind of artery, whether it's aorta or hepatic artery or mesenteric or whatever. And another case, this one looks like a pretty small IVC. There doesn't seem to be a lot of respiratory variation. So here we have the liver, we have the vessel, and it feels like it's relatively small, and maybe this right atrial pressure is not that high, right? That's what is the first impression. However, in reality, this is not IVC we are looking at. Like in this image, if you look at it, so this is the right atrium. And in this image also, like when you look at the right atrium, it appears unusually big, right, compared to the other images that we saw. So maybe this patient has elevated right atrial pressure, but how come the IVC is so small? And what's within the right atrium? This is most likely it could be a central venous catheter, or it could be a pulmonary artery catheter. In this case, it was PAC. Anyway, so the point is, like, we are catching it in oblique view, and when we are actually getting the IVC transverse, you can see that its diameter is not really that small. It seems to be a relatively big vessel. So this is the actual IVC in its long axis. What we are looking at here is just the right hepatic vein, because we are catching this IVC in oblique. So this portion is IVC at the mouth here, but all this thing is not the IVC. This is hepatic vein. This is another very frequent a frequent technical pitfall, I should say, that novice sonographers fall prey to. Is also commonly seen when I don't know if you do ECMO, but like when you're putting the ECMO catheter, the surgeon wants you to confirm that the guide wire and the cannula is in the IVC, and you're trying to look at this view, and you get this view, and you see, like, I'm not seeing anything in the IVC, and the surgeon says, I mean, it must be already in the IVC. I'm not sure why you're not seeing it. It's because you're seeing the hepatic vein, not the IVC. This also I put up on Twitter, and looks like only 30% of the people got it right, and most of the people still thought it's inferior vena cava. All these are very common mistakes. I see them every day, and that's why I think it's important to emphasize than talking about advanced concepts, because, like, if you don't get IVC correctly, then everything else, all the advanced measurements, would be pretty useless. So how about this one? Is this a plethoric IVC? It looks like a liver here and a pretty dilated black structure here, but it's unusual. Like, I mean, you don't see a beating structure here or here, first of all, and you don't see hepatic vein joining that. And also there seems to be some white dots within that vessel. So it seems odd. So what we are looking at is a dilated duodenum. So if you look at anatomy, here is the IVC and here is the duodenum. Normally you don't see it because it's a gas-filled structure. So air is white on ultrasound. You generally don't see that. And also, like, you tend to be more superior when imaging the IVC, and you don't come this inferior. But for whatever reason, the duodenum is dilated. The patient has ileus. It's filled with fluid. Fluid is black on ultrasound. So the distended duodenum with fluid can be confused with IVC depending upon your probe location, if you don't pay attention to the anatomy. So basically, IVC can be confused with the aorta, which is adjacent to it. It can also be confused with a distended duodenum. And so those are all technical pitfalls, right? Now, the more functional or clinical question is, like, does IVC alone change management? On the left, you have this image was also obtained from a nephrology clinic patient. This IVC is like pretty small and 100% collapsible, right? So should you ask this patient to drink more water? Should you ask this patient to eat more salt? Nothing. It's a normal finding. This is very important. A small collapsible IVC does not differentiate between hypovolemia and euvolemia. And some of you, like, if you do a POCUS course, and like if I image all of you, at least 50% of the people will have this small, completely collapsible IVC. It means nothing. It's just euvolemic state. So it only means something when you have more obvious clinical reason to suspect volume depletion, fluid loss. But if you really have that much reason to suspect fluid loss, you are seeing a burns patient, you are seeing a trauma patient, you probably don't need point of care ultrasound to know that. And on the right, you have a plethoric inferior vena cava. The right atrial pressure seems to be elevated, but should you always give diuretic to this patient? It depends. It depends on the clinical context, because if it's an acute dilation, yeah, most likely yes. Or if it's because of fluid, yes. But sometimes it could be because of pericardial effusion. And what happens if you have pericardial effusion and you give a lot of diuretics, and you remove fluid from the circulation and the intrapericardial pressure increases? thereby precipitating the tamponade. So, or this patient could have chronic pulmonary hypertension and dilated IVC at baseline, then giving more diuretics or ultrafiltrating them would probably reduce their forward flow or stroke volume. So we have to take all these findings in the right clinical context, and isolated IVC won't change management. And also there is another misconception. So especially when you read studies about mechanically ventilated patients and IVC, I just told you that like IVC shouldn't be used to measure right atrial pressure in mechanically ventilated patients. But generally, if you look at literature about IVC and mechanical ventilation, you'll find a lot of studies. Like, what are they looking at? They are not looking at the right atrial pressure. They are looking at fluid responsiveness. And there is so much debate about this and increased awareness about, yeah, you shouldn't give a patient fluid if the patient is not fluid responsive. That's true. However, should you give fluid to a patient who is fluid responsive? That's the real question, right? And this is also a myth. First of all, like IVC is not an excellent tool to determine fluid responsiveness. They have a lot of cutoffs and have a particular tidal volume number. A patient must be completely sedated, and you take off certain cutoffs. I don't even remember what are those cutoffs to determine whether the patient is fluid responsive or not. And why do we say that? Why do we say IVC is not a good tool to determine fluid responsiveness? First of all, what is fluid responsiveness? We are saying we give some fluid to the patient, and in response to that fluid, the patient is able to generate some additional cardiac output. So that is fluid responsiveness. The patient is responding to the fluid that you have given by increasing their cardiac output. So it makes sense that if the IVC is small and collapsible, the CVP is low. If you look at the Frank-Starling curve, yeah, most likely the patient is responsive to fluids. And on the other hand, if the IVC is pretty dilated and non-collapsible, the central venous pressure is high, and the patient is most likely operating on the flat portion of the Frank-Starling curve, yeah, most likely the patient is not going to respond to fluids because the heart muscle is already pretty stretched. But with the intermediate values here, if the IVC is big and completely collapsible or small and not collapsible, all the intermediate right atrial pressure values, they won't tell you if the patient is fluid responsive or not. That's why it's essentially useless. But whether you are using IVC or whether you are using a transduced central venous pressure, just by knowing a value of CVP, you cannot predict fluid responsiveness except at extremes. And also, not everybody's Frank-Starling curve is the same. So you can have a right-shifted Frank-Starling curve, or you have a more right-shifted Frank-Starling curve, depending upon the patient's baseline cardiac status. So IVC should never be used to assess fluid responsiveness. And again, the question comes back is like, what do you do based on fluid responsiveness? You're using point-of-care ultrasound at the bedside as a diagnostic aid, and you're saying this patient is fluid responsive. So what? So should I give fluid to this patient? What does it mean? Because fluid responsiveness is a physiologic state. All of us should be fluid responsive. If we go and inject ourselves with a half liter of normal saline, all our cardiac output should increase, and ultimately we pee that out to maintain euvolemia. So everybody must be fluid responsive. So exhausting fluid responsiveness is never the goal of the therapy. That's an important thing to note. Okay. And when interpreting IVC ultrasound, we have to take all these factors into consideration. It's not just about intravascular volume. It's if your intrapericardial pressure is elevated, as in pericardial effusion tamponade, or pneumothorax, left heart status, right heart characteristics, pulmonary circulation characteristics, pulmonary hypertension, or the patient has a lot of tricuspid regurgitation, or the patient has chronic pulmonary hypertension and his right atrial pressure is, right atrial compliance is chronically bigger. So all these things affect your IVC interpretation, or intra-abdominal pressure is elevated, like in liver cirrhosis patient, that ascites is compressing the IVC and making it look smaller despite a raised right atrial pressure. So IVC interpretation is really complex, especially if you don't do focused cardiac ultrasound simultaneously. And the next thing is the lung ultrasound. So lung ultrasound is POCUS is equal to lung ultrasound, or is volume status assessment is equal to lung ultrasound. So lung ultrasound is technically very simple, and a lot of studies have come out in hemodialysis patients. That's why there is growing interest among nephrologists and also intensivists. And intensivists have been using it for like ARDS and other things for quite some time now, but nephrology is relatively new, and their interest is mainly in hemodialysis patients. However, again, like I said, it's technically simple, right? You can't see lung tissue on ultrasound because lung is filled with air. Air doesn't allow the ultrasound beam to pass through it So all you would see are artifacts unless the lung is consolidated. So you have A lines and B lines. If you see horizontal lines, that's normal lung. If you see vertical lines, that's bad. B lines are bad. So the more the number of B lines or vertical lines, the more is the extravascular lung water. So let's see a few cases. So here is a patient with AKI on dialysis. The patient is oliguric, but there is no pedal edema, and the nephrology fellow has auscultated, and the lungs were clear. So nephrology fellow wrote for very minimal ultrafiltration. The blood pressure is also good. Okay, it's not, it doesn't seem to be too high. And ultrasound findings are shown below. Would you change ultrafiltration based on this? And you see, like, what do we see here? Like, we see a bright horizontal line, but beyond that, we see all the vertical artifacts, and vertical artifacts are B lines. And we showed all the 4 zones, like 2 anterior zones and 2 lateral and dependent zones. Basically, everywhere you see all those vertical artifacts. So we are seeing a lot of B lines everywhere. So this patient has pulmonary edema. And this is how A lines look like on ultrasound. So A lines are horizontal lines. The first line is a pleural line. And you can think of these horizontal lines as reflections of pleural line in a air-filled lung. So A lines are air-filled lung, and B lines are the vertical artifacts when you have increased interstitial thickening, typically because of fluid. And these move with the patient's breathing. That's why these are moving like the sun rays. So these are B lines, and the previous patient had all B lines. But why was the auscultation clear if you have so much B lines and pulmonary edema, right? So, like, when we think about sensitivity of physical examination, it's extremely poor. You'll be quite surprised. The sensitivity of lung crackles and peripheral edema was only 9 and 3%, and with a combined sensitivity of 13% compared to lung ultrasound findings for the detection of increased extravascular lung water. So but doing physical examination is like placebo. That's what I would say, both for the physician as well as the patient. Patient feels like physician is doing something, and physician also feels like they're doing something, but in reality, they're not doing anything. And not only in dialysis patients, it was also evaluated in ICU patients who are mechanically ventilated. And the combined sensitivity of crepitations and Ronchi was pretty low for detection of pulmonary edema. It's like flipping a coin. So you can be right or you can be wrong. And point of care ultrasound is more sensitive than even a chest radiograph for the detection of cardiogenic pulmonary edema. So it's pretty good sensitivity and specificity, surpassing not only physical examination, but also chest radiograph. Essentially, there is no role for daily chest radiographs in ICUs, especially if you are following cardiogenic pulmonary edema. I mean, there is still some role because we are only sono-auscultating few zones, and there can always be some zones that are missed when you're relying solely on point of care ultrasound, unless you do extensive lung ultrasound. So if your pathology is very diffuse or scattered, like viral pneumonia, interstitial pneumonia, yeah, you initially at least you need a chest X-ray. But for cardiogenic pulmonary edema, you never need chest X-ray. For all those dialysis patients who are high likelihood to have cardiogenic pulmonary edema, there is no role for chest X-ray anymore. So our case, all B lines, pulmonary edema. You should increase the UF rate. Here, another case, a patient presents with AKI and mild shortness of breath. Urine protein creatinine ratio is slightly elevated, 678. And lab reported 10 RBCs per high power field. Urine microscopy did not demonstrate any dysmorphic RBCs. And you perform physical examination while the workup is in progress. And when I say physical examination, I mean POCUS. I don't think there is any other physical examination in nephrology apart from point of care ultrasound. The rest is all placebo. But anyway, so this is what you find on lung ultrasound. We do see all these sun rays, right? You see all those vertical artifacts moving with the patient's breathing, and you assume that most of the lungs looked like this. But what's the difference between these vertical artifacts and the previously shown vertical artifacts? Let me remove my ink here. I don't know. Don't bother. So, and these don't seem to be like really uniform, right? Some of these seem to be like very white and hyperechoic, and some of them seem to be very pale. And also the pleural line here, it seems to be very thick and irregular compared to that previous pleural line, which was very smooth and without any interruptions. And you look at the pleural line with a high frequency transducer or a higher resolution probe, you can see all these pleural line interruptions, and these are subpleural consolidations. So this is highly suggestive of some lung pathology instead of cardiogenic pulmonary edema. In cardiogenic pulmonary edema, if there is no lung pathology, the pleural line is pretty smooth without interruptions. So this should alert you. It's not just the patient has AKI, not making much urine, so it's pulmonary edema, but you should think about something else, especially in the context of RBCs in the urine. Maybe this patient has some pulmonary renal syndrome. So without wasting much time, you send serologies and get a CAT scan if possible. Call pulmonary and do a bronchoscopy. You got a CAT scan, and this is how it looked like, all these ground glass opacities and stuff. So this patient did have ANCA vasculitis, and point of care ultrasonography has changed or expedited the management, I should say. And like if you, it depends so much on the operator, right? Like if you have just thought like it is some cardiogenic pulmonary edema and given some diuretics, that would delay care. Just because you did point of care ultrasound, it doesn't change. It won't improve patient outcomes on its own unless you interpret that in the right clinical context and change management. So the point is, B lines are not specific for cardiogenic pulmonary edema. B lines just represent interlobular septal thickening, and that septal lobular thickening is typically because of fluid in the nephrology context, but it can be because of fibrosis, or it can be because of increased permeability, that is acute respiratory distress syndrome, transfusion-associated lung injury, pulmonary contusion, diffuse alveolar hemorrhage, as in the previous case, interstitial lung disease, and so on, COVID-19. So basically, you have to interpret in the right clinical context. Here we have another case, a patient with end-stage kidney disease on dialysis, admitted for sepsis, which was presumed to be because of catheter infection. And medicine team has already performed point of care ultrasound, and they found all these B lines. Here you are seeing multiple intercostal spaces. So these are rib shadows in the middle, and you're seeing multiple intercostal spaces, and you see all these vertical B lines. So yeah, that seems to be true. So there is pulmonary edema. Should you do more hemodialysis and ultrafiltration? Yeah, possibly yes. But before that, we have to do something else. Isolated lung ultrasound is bad, right? So you look at the heart. So when you look at the heart, you see all these four chambers. Here is the left ventricle, and you see something here, right? So there is a valve between left atrium and left ventricle, which is mitral valve, and something is attached to the mitral valve. So there is a mitral valve vegetation here. So what's happening here? Valve vegetation or endocarditis is associated with valve destruction. So you have some valvular regurgitation. And where would that regurgitation go? That regurgitation would go through the pulmonary veins and cause pulmonary edema. So the cause of this pulmonary edema is endocarditis. So what would happen? You just rely on medicine team's isolated lung ultrasound. You go do extra sessions of ultrafiltration, send the patient home, but the patient is going to come back again because you haven't treated infective endocarditis. That's not good. So this particular patient underwent cardiac surgery, had a valve replacement and everything. So here is another patient with end-stage kidney disease on dialysis, admitted to ICU for post-op care following vascular access revision. And during dialysis, the blood pressure drops to 90s. Nephrology fellow goes and does isolated lung ultrasound and says, I see A lines, so that means there is no pulmonary edema. And the patient also doesn't have pedal edema, but feels slightly short of breath. And I mean, it doesn't look like fluid overload, but I don't know why the patient is a little short of breath. So what should we do? We should perform physical exam, right? So you look at the IVC. So you look at the lung, mostly A lines, okay. You look at the inferior vena cava. Inferior vena cava appears to be plethoric. And that's what I would expect, right? This patient is admitted for vascular access revision, not been getting good dialysis for the past few days. So most likely, unless the patient is making a lot of urine, which is unlikely, the patient should be having high right atrial pressure. But anything else we observe here? Here is the liver, here is the IVC. The IVC is entering the beating structure, but there seems to be some gap between the beating structure and the diaphragm. And what would the gap be? It's a fluid, so it's most likely pericardial effusion. So you look at the heart. So this is the long axis view of the heart here, and the four chamber view of the heart. And you can see that there is fluid around the heart. Here also you can see the fluid surrounding the heart. So this is pericardial effusion. So the nephrology fellow said they would reduce the ultrafiltration. Okay, that might initially work. But on the other hand, if you are just relying on isolated IVC ultrasound, then you would say the right atrial pressure is elevated, so remove a lot of fluid. Then what happens? If you remove a lot of fluid with dialysis, then you are removing fluid from within the heart, and the pericardial pressure would supersede the intracardiac pressures, and the patient will go into tamponade by the end of the dialysis. So relying on isolated IVC ultrasound is very bad. Relying on even isolated lung ultrasound is also bad, because like if you just relied on isolated lung ultrasound, did not do ultrafiltration, the patient would feel okay for now, but eventually you are not addressing the pericardial effusion, which is important. This is another case of pericardial effusion, and this is a long axis view of the heart. Here is right ventricular outflow tract, left ventricle, left atrium. So what else do we see here apart from pericardial effusion? All this black thing here is a pericardial effusion. But in addition to that, if you look at the right ventricle, it seems to be collapsing, right? So this is a right ventricular collapse during diastole. How do I know what is diastole, what is systole? Because here the mitral valve is open, so this is diastole. Normally you have EKG, but not all point of care ultrasound performing physicians use EKG. But if you don't have EKG, valvular opening and closing will tell you if it is systole or diastole. During diastole, there is RV collapse, so this patient has tamponade. So if this patient has, actually this was obtained from an ICU patient who had worsening acute kidney injury, and nobody did point of care ultrasound. Nephrology did it during initial consultation and found this. Immediately, pericardiocentesis was performed. And this is a short axis view of the heart, and here is the RV collapse also. And after pericardiocentesis, you can see that all that black thing has disappeared and the AKI has improved. And this patient's left ventricle doesn't seem to be squeezing well. That's another problem. But at least the pressure requirement has considerably come down. So the point is, this is pressure overload. And a dilated IVC does not always mean fluid overload. It can be pericardial effusion. It can be pulmonary hypertension. It can be acute pulmonary embolism. Maybe I'll just leave this case alone in the interest of time. So here we have another patient with cirrhosis who is being seen for AKI, and urine sodium is less than 20. And should we start albumin for presumed volume depletion? That's the usual scenario. We see a patient with cirrhosis and just give them albumin because guidelines ask us to do so. And that seems to be a genuine question. The urine sodium is less than 20, but urine sodium of less than 20 can occur in several causes, right? That can be because of volume depletion or cirrhotic pathophysiology itself because of the renal vasoconstriction, or the patient got intravenous iodinated contrast that causes the same phenomena, or it could be because of increased intra-abdominal pressure or early stages of ATN. So it really doesn't discriminate between the causes of AKI in cirrhosis. So you do a point of care ultrasound. Here the IVC is small and collapsible, and LV seems to be squeezing pretty well. So now can we give fluids? So the thing is, like, yeah, you can give fluids because the patient seems to be fluid tolerant. I mean, assume there are A lines in the lung and the right atrial pressure is not elevated. But like I said, the small collapsible IVC alone doesn't tell you if the patient is hypovolemic or euvolemic. Or in cases of cirrhosis, you can also have high output cardiac state. Then you look at the left ventricular stroke volume. So you do a Doppler assessment at the aortic valve and you get a tracing like this. This is the blood coming out of the heart with each beat. And if you trace this, you get a number in centimeters. You can use this number called velocity time integral as a surrogate for stroke volume. Discussion of stroke volume is beyond the scope of this talk, but let's look at what this patient had. So we did the Doppler assessment, and this number here is 35. And we said 18 to 22 is normal. And this is 35 centimeters. So the stroke volume is very high. And this calculated cardiac output was more than 10 liters. So again, the question is, just because somebody has a small collapsible IVC, it does not necessarily mean they need fluids. If you have a 10 liters cardiac output, what would your albumin add to that cardiac output? So this patient would probably benefit from early initiation of vasopressor, whether norepinephrine or terlipressin if you have. The thing is, like, if you keep giving albumin to this patient just because of small collapsible IVC, once you start terlipressin, because of the increased afterload, the fluid is going to go into the lungs, and that's why all the terlipressin trials showed increased incidence of pulmonary edema. And liver disease is a very under-recognized cause of high output cardiac failure. And finally, the VEXUS. I'm going to avoid this part, but I'll just say that VEXUS is something that's recently gaining prominence. It's a Doppler assessment of multiple veins now inferior vena cava is going to tell you about the right atrial pressure, but what next? For example, in mechanically ventilated patients, you don't know what to do with a big IVC. IVC can be just big because of PEEP and just because of mechanical ventilation. So you look at the Doppler patterns, how the blood is flowing through hepatic vein, portal vein, and intrarenal vein, all of which are ultimately draining into this right atrium. And if there are any abnormalities, based on that, you quantify venous congestion. And those waveforms change with the amount of fluid removed, and you can follow the patient and manage accordingly. And why do we care about fluid overload and kidney function? Because essentially, when you look at organ perfusion, it's the difference between the perfusion pressure is the difference between inflow pressure and outflow pressure. In the context of kidney, inflow is mean arterial pressure and outflow is central venous pressure. So even if the mean arterial pressure is well preserved, so that means the patient doesn't have hypotension, if your central venous pressure is elevated, your perfusion pressure still drops, and that causes interstitial edema, and interstitial edema increases the risk of AKI. That's a congestive AKI, and this AKI improves if you remove fluid. So basically, AKI is not always about giving fluid, but AKI treatment can be removal of fluid, or AKI treatment can be drainage of pericardial effusion, or AKI treatment can be giving pulmonary vasodilators to facilitate forward flow. And Vexus in itself is a whole lecture. I don't think there is any point of talking about it now in 1 to 2 minutes we have. We'll leave this alone. And if you go to nephropocus.com, there is a section on Vexus. You can see how I perform it, and there are several papers I've written about it, good review articles. You can read from the beginner stage and see how we utilize that in real life. So basically, in summary, this is how POCUS in nephrology or POCUS in critical care looks like, the real POCUS, not just isolated lung or IVC. You want to know how is the forward flow, what is the stroke volume. You want to know if the left atrial pressure is elevated, and consequently, if the patient has cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. Then you want to know the right heart status and the effects of right heart on the systemic venous circulation. So unless you master the POCUS technique and its correct interpretation, patient outcomes won't change. And everything can be overwhelming, like so many things that we are not taught in medical school. But everybody grows. Like initially, when I started doing POCUS, I started with IVC ultrasound, and I thought, okay, I'm an expert in volume status assessment because I do IVC. And eventually I learned IVC is not enough, then learned lung ultrasound because lung ultrasound is relatively easy. But then I realized IVC and lung are also not enough. I need to learn focused cardiac ultrasound. And cardiac ultrasound is not just for cardiologists. It's a vital component of hemodynamic assessment. And then I realized you need some Doppler skills. And now I do a lot more, like Doppler echo, Vexus, and everything. But I realized that there is a lot more to assessing hemodynamic status. And in some cases, it's not still very easy. So everybody will grow. So ultimately, you have to start somewhere. If you're a nephrologist, this is a recent position statement by the International Alliance for POCUS in Nephrology. We are, I think, a group of 22 nephrologists from around the world. We put it down like what are considered like POCUS applications within the scope of a nephrologist, and how do we conduct workshops and everything. So if you're interested in that aspect, you should definitely go through this and check out nephropocus.com. You'll have a lot of scenarios that I collected during my my career as a nephrologist, and that would be useful for your day-to-day practice. And with this, I'll finish the talk. A fool with a tool is still a fool. So you can have point of care ultrasound, or you can, in future, you might have even portable MRIs and everything. But if you don't know how to interpret the data and properly integrate that into the right clinical context, that would be useless. So thank you so much.
Thank you, Dr. Koratal, for such an insightful and comprehensive discussion about POCUS. Definitely the practical approach that you said will be enriching our understanding and also application at the bedside.
Most of the time, our patients are already on ventilator and they already have some amount of right heart failure, either due to mechanical ventilation or due to lung disease. So I think it is probably not related to your talk, but it is more related to Vexus. Sir, if it's okay, can I ask?
Yeah, go ahead.
Sir, when I have a case with Vexus 3 and I start decongesting, most few times I feel there is loss of forward flow. The Vexus grade doesn't decrease much, but the output stops. And sometimes I find that the portal vein pulsatility doesn't change, whereas the renal vein pulsatility and the hepatic veins size decreases. The grade decreases, but the portal vein pulsatility remains the same. And
So
how to use it
yeah,
in CLD, in CKD. When I try to explain to my nephrologist that I will use Vexus, he says in CKD there is no point because already the renal veins may not change much when it comes to color Doppler flow. Again, when it comes to cirrhosis, they say the portal vein pulsate is affected by cirrhosis. So we have to exclude one component for specific disease or still use it globally.
no, that's a practical problem. So there are two components of the question, right? So is Vexus applicable in mechanically ventilated patients? Yes, of course it is. And the original Vexus study was in mechanically ventilated patients. Does mechanical ventilation itself affect Vexus? Probably not. Like if you take a normal person and apply a slightly higher beep, it's unlikely that the patient develops venous congestion. It's mainly because of the lung pathology itself and the right heart status in the critically ill patient. The Vexus is changing. And second thing is, would Vexus change in everybody with decongestion? I would say it's a case by case scenario again. If the patient has chronic pulmonary hypertension, probably not. But portal vein Doppler is still helpful in those cases. And if the patient doesn't have heart failure at baseline or has very good decongested state at baseline, that is, you have a patient with heart failure with an ejection fraction of 30%, but their recent outpatient echocardiogram says their IVC is small and collapsible, compatible with 3 millimeters mercury right atrial pressure. In those patients, you could still try to decongest them completely and bring down all the Vexus waveforms to normal. But if the baseline is abnormal, you might not be able to get. And I don't know what, I mean, you said like sometimes the renal improves and portal doesn't improve. That seems to be a little bit odd. I mean, we have to see that particular case, but in general, logically, portal vein should improve uh, faster compared to other two components because portal vein is separated from the systemic circulation by hepatic sinusoids. So it's not directly connected to your inferior vena cava or susceptible to right atrial pressure, unlike your hepatic vein and intrarenal vein. And also sometimes where we sample also matters. It's only the main portal vein that has been studied. Sometimes you get a different waveform if you do sample the branches of the portal vein, that can cause some confusion in real life. And also whether you're doing intrarenal venous waveform or main renal venous waveform, that also can cause little confusion. And sometimes like even the segmental veins and interlobar veins, there can still be some difference. So all those factors must be taken into consideration. And when we say intrarenal, we are referring to interlobar vessels. And like I said, portal vein should normally improve unless you have catastrophic structural tricuspid regurgitation before both the other waveforms. And in CKD, whether it's useful or not, I mean, in CKD itself shouldn't really preclude. I mean, most studies excluded ESRD patients, but even if you have CKD, the renal vein would improve in my experience in most cases if the baseline is normal to begin with. But in advanced CKD patient waiting to start on dialysis, those patients we don't know. But if you don't have one component, I mean, if one of the components is not really reliable because of the liver disease or kidney disease, you can still use other veins, right? Like when you might not be able to calculate Vexus score, it's okay, but you get a sense of whether your patient is congested or not. You can look at the internal jugular vein, and internal jugular vein is essentially the same, essentially like IVC, right? Or more precisely, you can go to the suprasternal or supraclavicular area and find the superior vena cava. That would give you a good information like the hepatic vein. So on, like you can do the femoral vein Doppler that is gaining more prominence. So there are multiple things. So we call it E-Vexus or extended Vexus in such patients. And also just because somebody has cirrhosis, portal vein doesn't become unreliable just because of the cirrhosis diagnosis, unless they have severe portal hypertension and they're decompensated. Then they have like chronic arteriovenous malformations but we have presented all, I mean, like we have published all these most cases. You can go to nephropocus.com and see and some of these cases have cirrhotic patients and some in CKD also. And recently we published a case about femoral vein in ESRD, and that's gaining more prominence. Yeah, basically, yeah, you might not be able to calculate VEXA score, but don't get fixated on VEXA score itself, but look at other veins.
Thank you very much, Dr. Koratal.
Thank you so much. It's a pleasure to be here as a whole.